Hello,
Uh,
everybody.
I think it says it's preparing to setting up for YouTube Live. Okay. And then let me go ahead and go live on. Hi. Um, so now I'm going live on um Instagram,
Okay.
and then what else am I gonna do?
Okay.
Hi. Okay, we're live on Instagram. Happy Friday, guys.
Hello, everybody.
Hello, hello, hello. Welcome in. Hi.
I
Happy
sent
Friday.
a request for
Dr. Q
Instagram.
already said, oh, Dr. Q, you're like, you're
I'm
on
getting
it.
my brain still works.
Thanks for the hearts. Thanks for the hearts. Happy Friday. Happy Friday.
Oh man.
All right, perfect. We have Dr. Q
Yeah.
here. Do you guys have questions for us today? Hi, her blood story. How are you? Hello, hello. Welcome in. I'm caffeinated today, guys, so hopefully you get like an entertaining cast today. And the caffeine's actually working today. Like a little bit,
Yeah,
a
it
little
worked.
bit. Yeah.
I'd be sleeping
Um,
right now if I didn't have my double cappuccino.
no, really, that sounds like me. That sounds like me on most days. All right. Hi, Lady Sapphire. Thanks for sharing your story. Well, thank you for listening in. All right. Okay, so I was supposed to get us started. You guys, I'm behind here. I was supposed to get us started, but let's see who has the first question. Let's see who has the first question for us today. Hey, you guys, it's been a while. I know. I'm so sorry. It's been a lot longer than I expected. Thanks for the kisses. Mwah, mwah, mwah. All right, let us know where you're tuning in from. Let's shout out some cities, and then in the meantime, I am going to try and find a question for you all to start off with, unless somebody has a question to start us off with. I'll wait a couple seconds. Dr. Q, you have anything interesting going on this weekend?
Uh, I might go up and visit my daughter in Sacramento.
Okay.
I want him to come down here. Sacramento's is not quite as exciting as the Bay Area.
That's what, my parents moved up to Sacramento and I hate going there. Yeah, it's to your point, it's not
It,
exciting at all.
well, it's a long drive too.
And it's a long drive. It's like 2.5 hours,
Yeah,
2 hours.
yeah.
It's just, yeah. And then I got a crack in my windshield the last time I went up there. So I don't know. All right. I think I have our very first question. Hello, Lagos. Hi, Nigeria. Madison, Wisconsin. Ooh, ooh. Columbus, Ohio. We got Midwesterners. I'm a fellow Midwesterner from Iowa, DC, London. Hey, guys. All right. So, our very first question we have here. My daughter is 7 years old and she has never been transfused. Is that a good thing?
Yeah, that's a good thing. Um, so
I'd say so.
yeah, I mean, transfusions are have they're they're good if you're sick, but they have a lot of downsides. And since this question was asked, so everybody who has transfusions who has sickle cell disease should be getting what's called phenotypically or genotypically matched blood. So what we used to do when I was practicing is when kids would come in, they'd have a confirmatory test to show that the state screening wasn't a mistake. And when we drew that blood, we also drew blood to do a phenotype on the baby so that we would know in the future how to what antibodies were possible and we could give them what's called phenotypically matched blood. And people with sickle cell disease should always get phenotypically matched blood. It's not ABO, it's Duffy, Kell, and all these other proteins on the outside of the blood cell. And if you make antibodies against those, say like Kell, which is really common, then it means you can never get a transfusion from somebody who is Kell positive, who has that protein on their red cells. So the numbers of people that you can get transfused from get smaller and smaller and smaller. And one of the young kids I had to get his blood from the National Rare Donor Blood Bank in Washington, or no, in New York. And when they, if he needed a transfusion, they'd have to call out to all their donors around the country. And usually I think there were two donors in Florida who could give blood for him, but they were the only two people in the country. So phenotypically matched blood, um, for all your transfusions. And then if you're on chronic transfusions, you need to start thinking about iron. Iron overload is a big deal.
So it's good news. It's good news that you haven't had to
Yeah,
have a blood
yeah.
transfusion. Um, I get transfused once in a while, every so often. Usually when I'm about to travel, I'll get transfused just to have that extra safety. And it's nice. I'm actually probably working with a hemoglobin 9 or 10 right about now. So I'm kind of sitting pretty from a transfusion that I got back in September because I traveled to London for a meeting. So it's crazy how you can feel the difference. Like going into the transfusion, I felt like a zombie, and then coming back out, like I was skipping. I was like, is this how you guys feel? Is this how you guys are? This is how you guys live life? Like, I just had so much energy. So, but yes, it's great to hear that your child doesn't need a transfusion. All right, all right, I saw a second question come in. Oh, there's somebody named the Keith Project. I wonder what that's about. Hmm, okay. So what is the difference in having sickle cell and having sickle cell thalassemia? Good question.
Yeah, that is a good question. So sickle cell is everybody that knows that it's a mutation that changes an amino acid on the beta globin gene, and that leads to sickling because it changes the charge on the hemoglobin. Thalassemia is different in that thalassemia means that you have a mutation that either decreases the amount of beta globin that you can make, or if you have beta thal major, it makes it so that you can't make any beta globin, and then people with thal major need to have chronic transfusions for life every 3 weeks or 4 weeks. In terms of sickle cell disease, it can be beta thal zero, and that means that you have S beta zero thalassemia is what people call that, and it's the side effects of having that is just like having sickle cell disease because one of your genes doesn't make any beta globin and the other one only makes sickle beta globin. So the result of that is you're more anemic, your red cells are small, and you only make sickle hemoglobin. So you have the same problems as someone who has sickle cell disease or sickle cell anemia. But there's other mutations where you make a little bit of 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 normal hemoglobin, and that's S beta plus thalassemia. So the side effects of that depend on how much hemoglobin you make because it's not, you haven't eradicated the beta globin gene, you just have a mutation where the amount of hemoglobin is decreased. It can be decreased a lot or not so much. And depending on what that mutation is, will depend on how it affects you. So for instance, um, I had a young kid who people thought that she had beta zero thalassemia, but she actually had beta plus. But the amount of normal hemoglobin she made was so small, I think it was like 2 to 5%, something like that, that on screenings it looked like she had beta zero. So that's kind of the story with S beta thalassemia. And it's either S beta plus means you make some hemoglobin, and you and S beta zero means you make no normal hemoglobin, and it's the same as SS.
So essentially, so you can think of sickle cell, I guess sickle cell or sickle cell disease, right? I think when people say sickle cell, they mean sickle cell disease. You can think of it as an umbrella, and then there's different types of sickle cell diseases. And so sickle cell thalassemia or sickle cell beta thalassemia is one type of sickle cell disease. And then another type is SS, and usually that's referred to as sickle cell anemia. Another type is SC, and that's, or sickle cell SC disease, and then sickle beta zero, and then sickle beta plus. And then there's even others. Those are the most common ones, those top four. SS, I think, is the most common, and then SC, and then beta thalassemia. But then you find even rarer types of sickle cell where, there's like sickle cell SD and SO ARAB. And they're just like a whole bunch of other types of sickle cell diseases. And so if you just think of sickle cell disease as an umbrella, and then all of these different types of sickle cell diseases are underneath it, and they're different mutations, but it's different mutations paired with another. So S is always going to be the base mutation, and S stands for sickle. And then you put two S's together, that's SS. You have an S and a C, which is another different mutation. That's a different type of sickle cell disease. You have beta thalassemia with S. That's another type of sickle cell disease. So hopefully that makes sense. And so it's as Dr. Q was saying, thalassemia, or beta thalassemia is kind of another marker within your hemoglobin that determines how many blood cells that you make. So hopefully that's helpful. Usually when people say sickle cell, they mean like all of the types of sickle cell diseases. And then when somebody says sickle thalassemia or sickle beta thalassemia, that's one type of sickle cell.
And even S beta plus, where you do make A, that doesn't completely protect you. So it depends on how much hemoglobin A you make. And I had uh, young kids who had S beta plus thalassemia who had pretty serious complications. Although as the hemoglobin A gets higher, you can have kids who don't really have any symptoms at all.
All right. Um, Here's a question I haven't seen in a while. This one was sent in online. What is pulmonary hypertension? Well, this question has two questions in it, but the first question is what is pulmonary hypertension? And the second question, and your thoughts on Indari. But let's just go ahead and focus in on the pulmonary hypertension.
Yeah, so pulmonary hypertension is really common in people who have sickle cell disease. And what it means is that you have damage to the pulmonary arteries, and the heart has a hard time pumping the blood into pumping blood into the lungs. And because because of that, the right side of the heart gets damaged, or it gets um, it enlarges and it has a hard time pumping blood into the lungs. So it's usually progressive, meaning that as time goes on, it can get worse and worse. Um, there are treatments and for pulmonary hypertension to decrease the symptoms, but there's no way to completely eradicate pulmonary hypertension. Once you have pulmonary hypertension, then you have to be under a cardiologist care so that they can monitor you and make sure that that it's stable and you're getting the treatment that you need. So pulmonary hypertension is a serious complication of sickle cell disease, and you really need to be seeing your primary and a cardiologist to take care of that. And then the other one was Indari.
I'm gonna skip over that one for now.
Okay.
Um, this question says, debunk the myth for providers. If someone doesn't appear to be in pain in the ER with SS, they can still be in a pain crisis. Thank you for that. That's
Yeah,
super important.
there's something that one of the things that hopefully this is getting more and more uncommon. But one of the things sometimes will happen in the ED, and you have to remember when you go to the emergency room, they're emergency room doctors, so they're not hematologists. They may have and sickle cell is a rare disease, so they may see, depending on where you are, if you're in Chicago or in the Bay Area, you probably if you're an emergency room physician, you're going to see sickle cell patients more frequently. But if you're off somewhere else, then that person who's taking care of you may have never ever seen someone with sickle cell disease. So they will frequently, not frequently, they'll occasionally will do a blood test and they'll look at your blood and they'll say, well, you're kind of anemic, but I don't see any reason why you're having pain. Your blood count
Can
looks
I ask a
okay.
question? But can I ask, so if they don't typically see people with sickle cell, how do they know what to look at a lab to determine that you're not in pain?
Because it looks they know you can see that you're anemic, but they don't. But somehow they think that there's going to be other abnormalities there
Exactly.
that indicate pain. But there is no blood test, any kind of blood test to tell whether or not someone's in pain. So that right there is not valid. And the only thing, if you're treating people with sickle cell disease, you have to believe what they're telling you because you can't see pain. There's no test for pain. And if they're having pain and they tell you, that is the only way you're going to know what's going on. And you you just it's there should be in a large city there should either be some kind of protocol about how long you how you triage people with pain, so they shouldn't be sitting in the waiting room. They should be triaged like somebody who has a major medical problem and get into the actual ED and start getting sometimes they'll give an intranasal fentanyl just to get things started. Then they'll start an IV and give pain medication. Um, but the, the vast, if you're not near in a big city, you really need to have a, or even in a big city, you need to have a document from your primary care physician certifying that you have sickle cell disease because they may not believe you have sickle cell disease because you look fine. Um, and then also a pain plan. So the ED doc looks at this document, it's says you have sickle cell disease, and this is the recommendation that you initially get, maybe intranasal fentanyl. You're used to getting Dilaudid or morphine at a certain amount, and so that when you go in, you don't have to kind of like have a conversation about, well, because a lot of time, and the other thing that kind of gets into it is you will tell the ED doc. Usually when I come in, I usually get intranasal fentanyl, and then once I get an IV start, I'm getting like 2 milligrams Dilaudid every so often, and they're going, "Whoa, whoa, wait a minute! How do you know that? You must be a drug addict, you know?" So there's a lot of things that go into it besides the health disparities of the fact that the treating doctors probably looks like me and the patient looks like Cassandra. And so that maybe not that cute, but
Oh,
but it's white. It's a white doctor and a black patient, and depending on a lot of different things, people have biases that they're not even aware of. So
yeah.
it can be. The other thing is, if it's possible, bring somebody with you. Because if you
Yeah,
don't feel good, you're not going to be able to communicate very well with the physician. And if there's a witness, then the whole dynamic changes. It's like the
yeah.
doctor can't hassle you because now there's a witness that can say, "Hey, we were in there, and this doctor did whatever." It just changes the dynamics, and you need somebody to be your advocate while you're in there, if that's at all possible. It could be a friend, it could be a relative, your spouse, something like that. If you're older like me, it could be your kid, you know. Um, so it's a big,
Yeah, it's a big issue. It's a big issue. A lot of most providers actually won't know about sickle cell if we're being honest. And so it's always an uphill battle when people go and seek, care within the ER, and we call this ER utilization for sickle cell. And so what we always do is we encourage people to find a health home so that people get used to seeing your face, they get used to seeing you. Like Dr. Q said, having a pain plan and maybe even having your hematologist work with the ER that you normally go to, or work with the hospital that you normally go to receive care, because each hospital have their own policies on pain as well. And so even sometimes, even when you have a pain plan, and it may say, this amount, Dilaudid, this amount or whatever, it may be against the hospital's policy to provide that amount of pain medication. And so you kind of have to you kind of have to have your own, I guess, home hospitals or places that you go to frequently, so you understand what the hospital policies are, and then you can bring those policies back to your hematologist, and they can kind of create a pain plan based off of that. Because I do see a lot of friction where people come in, they do everything right. You talk to your hematologist, you guys created a pain plan. My sister always goes through this. You've created a pain plan, you've detailed every single thing, you hand it to the doctor, and they're like, oh, that's not our policy, we're not going to do that, we're not going to give you a PCA, we're not going to do this or that. And so you've done everything right, but still don't get care. And so I think you have to take it a step further where, if you look at the surrounding ERs, and this is if you absolutely have to go to the ER, because I would say first and foremost, you should go to a day hospital or a sickle cell clinic instead to get pain medicine, because these are people who actually know about sickle cell. These are people who can help you beforehand. This is like when you're feeling that pulsing, like you feel like a crisis is coming on. That's when you call your provider. That's when you call your hematologist and say, hey, can I get seen? So hopefully that's the route that you take before. But if you're not able to, and you do find yourself in the ER, you have to understand what the hospital policy is, and you have to be able to work within those limitations, or as you're just not going to get. And even that's not even a foolproof, right? You might come across a doctor with an ego, you might come across a doctor who is unwilling to listen to you. And so unfortunately, it's a huge issue. um what I will say about the ER, um, unfortunately, I feel like everybody has an issue with with the ER, even outside of sickle cell. And so it's a huge problem to fix. It's not just a sickle cell thing, even though it's worse for us with sickle cell patients, but I just feel like it's a global thing. Going to the ER is not never a great experience because of that. You have like all the problems of all the health problems of the world coming into one place, and it's just kind of juggling that. And sickle cell is already rare. I think a lot of times we all feel that everybody should know about a rare disease. Um, but not everybody knows about a rare disease. And when I say rare disease, I mean here in the US or the UK. Now, if you're in Nigeria and you roll up to the ER, you say I have sickle cell, they know exactly what sickle cell is. Or in Jamaica, or places where it's very, very prevalent. They know where it is. But when you're in places like the UK or the US, I think we're far and few, and that's what causes friction, and that's what causes opportunities for mistreatment. And so just kind of just understand your surroundings, even if you're traveling. Take a look at the hospital, take a look if they have a hematologist. Not only if they have a hematologist, but they have a hematologist that understands sickle cell is important too, because not every hematologist understands sickle cell. And maybe they don't have a hematologist, but they have a sickle cell specialist or somebody who understands sickle cell as well, who can help you. And so you got to kind of do your homework, to give yourself the best chance when you do roll up into the ER, because it's tough. It's tough. And it's an issue bigger than sickle cell. But unfortunately, it can have really grave. We've lost people within the ER. It's really the worst place you can be. So even before that, I'm always telling my sister, like the very first inkling of pain, the very first inkling of anything, try and call your provider, your hematologist, your sickle cell provider, and see if you could get seen in clinic first. So that's my 2 cents.
And if you're traveling, make sure you have that letter, and you should
Mm,
um, call your somebody is always on call, and you're at the covering for each other. And you need, if you're going to the EDs and you're not in, your home area, you need to let somebody know, I'm going to the ED, I've got these symptoms, I've got my pain plan with me. Can you call the ED and let them know I'm coming?
yeah.
And so
I
that's a
used to
thing.
blow up Dr. Q's phone, and Dr. Q, I'm going to the ER. And he's like, the bet, I got you. And he
Yeah.
calls in beforehand. You need that type of person kind
Yeah.
of advocating on the other side for you.
Yeah. So if a doctor calls the ED and says, "Oh, I'm Dr. So and so from the sickle cell program in Oakland, and my patient so and so is coming in, and they have this, and they have a pain plan. So if you have any questions or anything, here's my phone number. Give me a call." Um, and so if you have a good sickle cell doctor, that's what they should do, especially if you're out traveling and you're somewhere in the middle of who knows where. I mean, unfortunately, I've lost patients in California in the valley where people didn't know anything about sickle cell, and you never know what happened, but uh, nobody who goes into the ED should, everybody who goes into the ED should walk out of the ED. And you need to try to facilitate the best care you can get. It's difficult.
Yeah. Try and avoid the ED if you can. That would be
Yeah,
my
that would,
first, the best advice.
yep.
You guys, these are such great questions. I'm still like typing frantically. Let's see what the next one I have here. This one, I don't think we've ever gotten this question. What is the difference between African sickle cell, African American sickle cell, and Indian sickle cell?
Well, I mean, if you're talking about is SS different in one country than it is in a different country, than it is in a different country, they're all the same. But there are everything, I say this, I feel like I say this every time, but even siblings with the same parents can have completely different symptoms. So if you're in India and you have sickle cell disease, the background genetics is different from somebody who is, say, in Brazil who has sickle cell disease. So there could be some subtle differences between the presentation and the symptoms of those people. The other thing is people treat sickle cell differently in different countries and even within the same country. So depending on the treatment you've had in the, as you throughout your life, that will also change the presentation. But the genetics of it is exactly the same. Everybody with SS is homozygous for the sickle cell mutation, but the background genetics from your parents are going to affect that. And nobody really, as far as I know, nobody has really pinned down why some people, siblings say, have different symptomatology and their complications are different and all that kind of stuff. Um, People have done genetic studies looking at that, but they're never very, and at least in my reading, and I don't, maybe I just am missing something, but in my reading, it doesn't really help, you know, um, the understanding of why siblings and people have different presentations of their sickle cell disease. And it goes, there could be, a lot of it depends on fetal hemoglobin. So some people may have a mutation where they have SS and their fetal hemoglobin is higher than other people. It doesn't have to be super high, like 20%. It could be like 10% or something like that. And that is going to change the way your sickle cell presents over time. So
I have a question. Well, okay, I want to say sickle cell, if you go back in history, it originated in different parts of the world, and those are called the haplotypes of sickle cell. So you see, one of the mutations springs up in West Africa. One is like, within the Middle East, if I'm not mistaken. And so there are different points in history where you see like, different, I guess, variations of sickle cell pop up. Not that that has anything to do with like, race or anything, but Dr. Q, I feel like you said once before that, usually white people with sickle cell, when they go up into the mountains, they get like splenic sequestration. Is
sequestration.
that
Yeah.
is that correct? And so I guess, are there, I feel that we couldn't ever say like, if you see a white person with sickle cell, oh, our sickle cell is worse than yours, right? You can't really say that. I even see people with SC and SS, and people with SS saying, oh, our sickle cell is worse than, people with SC. Um, because sickle cell is so individualized to people. But are there any other patterns that you see where, is it simply because, do white people get more splenic sequestration within the mountains because more white people are generally in the mountains? I don't know. Does that sound weird? Does that sound bad? I don't know. Like,
I don't know that people with sickle cell trait can get splenic sequestration when they go to high altitudes or whatever.
was it
But
sickle cell trait?
I'm not sure about sickle cell. If you have, well, for one thing, people who are Caucasian or white, whatever, they may have sickle beta thalassemia because they they might. So so that's going to present a little bit different. So the few kids that I had who were really, blonde hair, blue eyes type of white kids who had sickle cell disease, usually one of the parents had beta thalassemia and the other person had sickle cell trait, so they had S beta thalassemia. Um, in terms of the difference like I was saying, in terms of the difference is the genetic background behind the SS. And
Mm.
in fact, SS, what I'm kind of interested in this in a little bit. So SS actually started in Africa, and they can almost pin down the place in Africa where it started and the migrate, and some genetic people, they use SS to follow the migration of people out of Africa because they can test people and see how many people and who has sickle cell disease, say in India, in Saudi Arabia, and then further out. So some people are very interested in tracing the migration of people out of Africa using sickle cell disease as a marker. But it did originate in one, I can't remember, I think it was the Democratic Republic of
Republic of
Congo.
Congo.
I
Hmm.
think that in that area is where people think it started. And then from there, it went into up into this into like even into the Mediterranean, the Arabian area, and into India. And then on this side of the world, almost all the sickle cell disease was due to, well, I would say all the
The
sickle cell disease
transatlantic
was due to the slave trade.
slave trade.
And people think, and that includes South America. So there were
Yeah,
people in this hemisphere who have sickle cell disease. It was secondary to the slave trade, and people, um, yeah. So
so yeah.
people don't really realize how many Africans were were brought
Enslaved.
over here and enslaved. It's not a
Yeah,
few; it's millions in
yeah,
South America, the Caribbean, and the United States. If you take one country, okay, but we're talking about the entire Western Hemisphere, and it was unbelievable how many Africans were put on ships and brought over here. More than
yeah,
I read an article somewhere a little while ago, and it was way more than I ever thought.
yeah, yeah,
Many millions. A lot of them didn't make it because they died or the ship sunk or something like that.
yeah. It's a crazy thought for sure. And I think one of the very first historical studies showed that, the very first Western recording of sickle cell was a slave that was trying to escape, and they found an absence of a spleen in that person. And so it really goes to your point. Yeah, that's why we have sickle cell over here. It's also why it's considered a rare disease here because it is less than 100,000 Americans um, with sickle cell. Whereas you go to the origin, which is, Africa, you see 1 in 4 people with sickle cell
Yeah.
trait, whereas here it's 1 in 12. So the
Yeah.
frequency is way,
In
way higher.
Africa, hundreds of thousands of babies are born with sickle cell disease every year.
Yeah. Um, I'm gonna skip ahead to a question here. It says in Algeria, the ER, since we're talking about Africa, in Algeria, the ER don't accept us, unfortunately. They say you must go to your hematologist, just that one hospital in particular. Okay, that was a comment. Um, but I think this is in regards to you. It sounds like you're not even allowed to go to the ER. You're turned away and they say, hey, go to your specialist. I wonder how well that does or doesn't work out. Yeah. And then somebody else says, even if you're in extreme pain, they reject us. Yeah. Okay. Please help me. Recently, I was diagnosed. My It says they're diagnosed with osteonecrosis of the left femoral head, and of at the head of a surgery that appears to be drilling in order to reset a good. Okay, so this person's asking about avascular necrosis, and it sounds like they got the cord decompression procedure to see if that helps with blood circulation to the area. Um, and this person, I just want to let you know that's something that I've undergone myself. I had AVN within my right hip. And before deciding if I wanted to do surgery and get the hip replacement, I did actually do the core decompression where they drilled in to help create new blood vessels within that area so in hopes for blood to go into that area and kind of to revive, I guess, the tissues and the bone tissue within that area. It wasn't successful for me, so I ended up having to get the hip replacement, but it is a procedure that a lot of people do go for, before getting an actual hip replacement, just in case it could help. Do you have anything?
Well, the core decompressions are very successful and they take the pain away. I don't know if it was your experience, but they usually takes the pain away initially. But over time, the damage to the head of the femur is progressive. So it delays the time maybe that you need before you get a full hip replacement, but eventually I'm trying to think, is there, I've personally never known anybody who had osteonecrosis or avascular necrosis of the hip who didn't go on to get a hip replacement at some point. Um, there, there was a study at Children's Hospital in Oakland showing that just doing physical therapy could help decrease the pain, but it didn't stop the progression, and those people ended up still getting a hip replacement. Um, so I think I think, getting a hip replacement it's not like a nothing thing. So I think it's worth sort of trying things that will prolong the time before you get the hip replacement. You don't want to wait too long. You can do a hip replacement at any point, no matter how, but the longer you wait, the more you're going to be in pain and the more damages or changes are actually in your leg because you're not using that leg. And so you can get what are called contractures that are minor that and the other thing is if you really aren't using that leg and you're putting all the stress on your other leg, then you can end up having bilateral AVN, which is not good. So, yeah, it's
Which is
probably
AVN in both.
yeah, AVN in both hips. So I think it's not a bad thing to do things to sort of put off the surgery a little bit, but I think anyone who has AVN should just in their mind be thinking, well, someday I'm going to need a hip replacement. And
Mhm.
even if I do these things, it's gonna give me some time to think about it and
Time.
kind of
It's
get
buying you
ready for
time.
it, but it's
Yeah.
not gonna cure my AVM. The circulation to the head of the femur is very tenuous, so once that vessel gets damaged, then the hip the hip dies, the head of the femur dies, and becomes osteonecrotic. And if you don't do anything, eventually the head of the femur will actually fuse to the acetabulum, the part uh, on your pelvis, and then you can't do anything. You can't sit up like I'm sitting up. Um, you have a lot of disability. You can still get a hip replacement, but it's like you've gone through all this pain and whatever when you could have gotten a hip replacement and had a lot less pain problems. You should also, if it's possible, make sure you have that hip replacement done in a sickle cell center where people know about sickle cell disease, how to treat you, the follow-up and all that kind of stuff. The follow-up is probably the most important part. You can't sit down and say, okay, I've got my hip replacement. I don't need to do anything. You can ask poor Cassandra. I bet she was up the
Yeah.
right after the hip replacement.
Yeah. I finally thought I was gonna get rest. And and they're like, nope, up, 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 up. We're getting up right now.
No, you got
I'm
to get
like,
up and
bro,
get moving.
I just had surgery. They're like, nope. Um,
But you need to do that. If you don't, then you know, you're going to be having problems with your hip if you don't do anything. You got to do the physical therapy.
for sure. Okay. So many good questions here. Like, so really, very, very great questions. I've got a guess. I'm from Nottingham, UK. We have a new consultant who is saying it's a fact that after having an exchange, our crisis pain should vanish within 3 days. Is that true?
No. I mean, if you have exchange transfusions over a period of time, your pain should decrease. But just like what we were talking about, if you have AVN, you could get exchange transfusions like forever, but the AVN is still going to hurt. Um, Exchange transfusions over a period of time will decrease your pain significantly. And if they're done, if they're done the way I tried to do them, it also decreases your iron overload. So exchange transfusions are really life-changing. The problem is access. Do you have to have a really good veins to get exchange transfusion? And if you don't, then you have to have some kind of a port or some kind of a device for the transfusion, which in itself has complications, getting clotting and infection and things like that. But the exchange really is definitely life-changing if you can if things go well. But even people who have bone marrow transplants continue to have pain sometimes for 6 months or longer after a transplant. So they don't have sickle cell anymore and they still have pain. The the it's it's a physical thing. It's also neurological. So it sometimes takes a long time to recover from having chronic pain for maybe years before you start some kind of therapy, either exchange or a bone marrow transplant. Most people, they do very well. Their pain goes away after a month or so, or even quicker. But there are people where the pain just doesn't go away as easily as that.
Yeah, even after I get a transfusion, I always feel weird. Because the volume of blood,
Yeah.
is goes up. And so I just don't feel like myself. I feel weird in my body. And that takes like days or maybe a week to like feel normal. So and I swear I would have a crisis, where have some sort of sickle cell pain after the transfusion. So that's definitely not necessarily the case. I'm gonna go to the last question that was posted. I'm kind of jumping around, guys. So if you really want your question, I'm gonna do another question after this person said, I'd like to inquire what resources or assistance you'd offer us for jobs. So I'm gonna get to that question after this one here. This one is my 12-month-old was in the hospital, high fever for 4 days, and one leg swelled and hot when he had a fever, had an MRI and a biopsy, done nothing, found, but what could it be the reason he was in this crisis?
So I'm assuming the pain was in that leg that was swollen up. Anyway, so you younger children who have pain episodes, they can have swelling. There's dactylitis where you have infarcts in the bones of your hand. The hand can swell up a lot, and because they're they're small. An infarct in the femur, in the middle of the femur, could cause swelling in the leg. Um, I've seen people, not infants, but young people who have infarcts in their face and they get like a black eye or their face swells up, really painful.
Yeah.
So there can be swelling and other effects of having a pain episode, um, particularly in little kids, just because their bodies are smaller, you can see swelling in their in the area where they're having this pain episode. So that's not unusual. You want to make sure that they don't have something going on there. So you might do an X-ray or something like that to make sure everything looked okay.
Okay. Next question I have is I'd like to inquire what resources or assistance you'd offer us that work at jobs that require us to be physically on site. So I'm having several days in pain, um, that I just kiss out on pay.
So people with sickle cell disease, they can do just about anything, but they can't do everything. Um, and I had a young lady who was she was a tough cookie, and she decided that she was going to be an electrician. And so she became an apprentice to be an electrician, but unfortunately where she was doing her apprenticeship was a huge building in the Bay Area. During the winter it was really super cold, and she was in pain a lot, so she couldn't really do that. So there are jobs that you just it there, and it was physical. I mean, she's climbing around doing whatever, but she couldn't do that. If you have AVN or other problems like that, then you have to modify your work, where you're going to work. One thing you need to do, which I think is maybe almost counterintuitive, but you need to let your employer know that you have sickle cell disease. You can't just like disappear for 2 or 3 days and say, "Oh, I was sick."
If you're in the US.
Yeah, if you're in the US. You can't just disappear for a couple of days and just say, "I just didn't feel good," and then that happens like every couple of months. That they're going to start wondering why you're not coming to work. But if they know you have sickle cell, and in the United States, there's the there's a law that says you can't discriminate people against people who have uh, disabilities. So uh, here in the United States, your employer knowing you have sickle cell disease is actually a plus, because then they can't discriminate you if you miss work. Um, but you do have to think about standing, carrying things around. Um, those kinds of things are going to put more stress on your body, and it'll take a toll. You need to kind of figure out a job you can do that's more less physical, and not standing around a lot either, because that'll cause you to have problems. And it depends on just who you are and a lot of things around your sickle cell disease, but you got to accommodate yourself to try to get employment that you can actually do and not get sick from it. Like being a carpenter may not be the best job for someone who has sickle cell disease.
Yeah, we're really great at using our brains, guys. And just yeah, we're just really, I think our strongest muscle is our brains. So, um, do with that what you will. Um, I see your guys' questions. I'm trying to get to it as fast as possible. This person said, I'm scared my daughter barely have crisis. My question is, will it change when she grows older? Does it get worse as she grows older?
Generally speaking, and when I'm talking about older, I'm talking like in your 20s and 30s. So generally speaking, over time, you can have more problems with your sickle cell disease. One way to uh, prevent that from happening is to do, everybody who has sickle cell disease should be on some kind of medical therapy. And hydroxyurea now is one of the therapies that's available. It's been available for 30 years, actually. Um, and it actually changes the course of your sickle cell disease. So if you have a young kid, people will start hydroxyurea as young as 9 months old or maybe even a little younger than that, but because it prevents organ damage. It increases your fetal hemoglobin, prevents organ damage. So the younger you can start it, the more benefit you're going to have, and you're you will have it's just it can be very life-changing. You need to have somebody who is familiar with hydroxyurea who is prescribing. So there's different ways to do things. Some people will pick a dose. They'll start you and they'll start you on a dose and they may increase it in a child as they get older, but but it's not what's called the maximum tolerated dose. Other people will push the hydroxyurea dose until the white blood count just starts to go down a little bit, which it's elevated in sickle cell disease, and they may have uh, a, a, a white count that they're targeting so that they know that the hydroxyurea is having an effect. So different people have different ways of monitoring hydroxyurea, but you have to have somebody do it who's very familiar with the medication and the side effects and all that. But that is one way. And then there's other in the next 5 years, maybe 10 years for sure, there's going to be new medications that will increase your fetal hemoglobin to levels that people didn't think was possible. And there'll be oral medications that you will take a pill and they will um, activate that they will decrease the genes. They will turn off the genes that make that decrease fetal hemoglobin when you become an adult, and your fetal hemoglobin will be 20% or more, maybe, and you
Yeah.
won't have any symptoms. That's not going to happen tomorrow. But a good thing is to start hydroxyurea now so that when these things are available 5 years, 10 years from now, you will not have any organ damage and it'll be a benefit. Um, so yeah, and
My,
there's new medications in the pipeline, and they will definitely be available within the next 5 to 10 years.
yeah. My advice for this person is enjoy your daughter. Enjoy the fact that she's barely in crisis or barely in pain. Um, Sickle cell, there's no rhyme or reason. And so her symptoms may get worse, or they may stay the way that they are, right? I think what a lot of people don't know is if you're not in pain, it doesn't mean you're not sickling. I think people, when they think about sickle cell, they think, oh, you're only in trouble when you're in pain. But like for me, as of right now, I'm not in pain, but I'm still sickling. So that the red blood cells are still breaking down. There's still damage to my organs. There's still all of that stuff, even though I'm not in a pain crisis right now. So I think it's important to remember that because or to know that rather, because a lot of people just think, oh, sickle cell is when I'm having a pain crisis. It's constant. It's constantly every day, every minute of the day. Sickle cell is sickle selling. And so, that's one of the reasons why I started hydroxyurea was to slow that damage down, slow down the damage of sickle cell so that I can protect my organs. I didn't start hydroxyurea necessarily to be in less pain, although people do say they experience less pain when they're on hydroxyurea. I did it to preserve my organs. I have an 11-year-old daughter that I want to be around for. And, you know, Dr. Russell Ware, he was giving a talk and he's like, it lowers mortality rate within sickle cell. I was like, I want to live longer. Yeah, let's go for it, right? So I just want to make sure that you all do know that sickle cell still happens in between the pain crisis. Um, the other thing I'll say to this is I I grew up like probably I call the hospital my second home. I was in the hospital probably on a monthly basis when I was growing up from like in my childhood. Then I actually moved from Iowa. I was born in Iowa, moved from Iowa to California, and my health did a 180 and I was barely sick. So like high school, all throughout like probably the last year of college, I didn't have anything. I didn't even I thought I didn't have sickle cell, or I thought like I think they may have misdiagnosed me. I have SS. I thought I had SC because I just didn't have any complications. And then sickle cell went knock, 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 knock. Did you forget about me? I'm here. And then that's when I ended up getting a vascular necrosis. And I actually, the year that I graduated, I had to get a hip replacement. And so sickle cell always finds a way to remind you that it's such a hater, but that it's there, right? And you just never know what you're going to get necessarily with sickle cell. And that's the scary part. And that's the hardest part about sickle cell is its unpredictability. So enjoy the time that your daughter is not sick and not in pain. And, maybe whatever is happening with her, you're doing right, or, it's working out for her. A lot of that may have something to do with her genotype. I don't know if she has a specific genotype, but you also have to kind of look at what her genotype could be. Maybe she has a milder genotype, and even milder genotypes, people end up in the hospital. But I guess continue what you're doing and don't be scared of it. Just be proactive. And a way to be proactive is, starting your child on hydroxyurea, so that you can slow down that pain or that damage that sickle cell might be causing. So that's my 2 cents. Hopefully that was coherent enough.
What I used to
Um,
tell parents was, don't, you know, mothers are very protective of their children, which is good. But you can be overprotective. And what you should try to do is let your kid do things that seem reasonable. Don't, feel like they're so fragile, they can't go outside, they can't do, they can't play with other kids, they're going to get sick, whatever. I think you have to try to treat your child who has sickle cell disease as a normal kid with this kind of this problem called sickle cell disease. And this, like Cassandra is saying, sickle cell disease will tell you what's going on. You're going to, if it's not an invisible thing. If you get sick, you know you're sick. And you also, as a parent with a young child, you need to be educated about sickle cell disease. You need to know, fevers are really serious and you need to be seen by the doctor ASAP, that there are complications that you need to be aware of. So ask a lot of questions and try to get as much information as you can about sickle cell disease. And on the Sickle Cell 101 website, there's a lot of information about sickle cell disease so you can inform yourself.
I got you. Thank you to the person who keeps reposting their question. I'm doing it next. But I just wanted to quickly say that I haven't been in the hospital since 2017. And so there's two of us in my family with sickle cell. We both have the exact same genotype. And my sister, she's hospitalized probably on every 3 months or so. So it really is variable per person. And you should just kind of keep an eye on what that might look like. But yes, I'm on a hydroxyurea, and then I'll get transfused when I'm getting ready to travel, for example, and that's the reason why I'm hyper today, or energetic today. I do have blood. I have great donated blood. But yes, and so just keep an eye on that, right? And that might be your daughter's trajectory, and fingers crossed that it is, that she just doesn't have pain crisis. Like I said, I haven't been hospitalized since 2017, and I have SS, which is considered the most severe. So hopefully that's the way it scopes out. Um, Somebody is asking how to stop frequent sickle cell crisis. Thank you for asking it over and over again. I wasn't going to pass you up, I promise. How to stop frequent sickle cell crisis.
So, well, as we've been harping, hydroxyurea is a way to stop, to decrease sickle cell crisis. Um, if you have, if you, it's hard to say, but if you're really having a lot of sickle cell related problems and whatever, crisis can mean anything. It can mean acute chest syndrome, AVN, all kinds of stuff. So if you have frequent sickle cell related problems, one in a lot of pain, one way to do that, one way to stop that, and I'm not advocating this, I'm just giving you one avenue, there are a lot. One would be just to start hydroxyurea and be very cognizant of how much you're supposed to take. Get a good doctor who can change your dose depending on what your blood counts show. Another, depending if you're really, really incapacitated, would be to go on transfusions, chronic transfusions. I mean, I did this when I was in practice, and then wean the person onto hydroxyurea if they were really, in the hospital all the time. Um, but and the other thing is to like start something, talk to your doctor. They know more about you than anybody. So talk to your doctor, what would be best for me to do? And they may say, well, you start hydroxyurea and then we'll see how you do or whatever. The other thing is to take care of yourself. Make sure you're drinking a lot of water, you have a good diet, you're getting sleep, all that kind of stuff. There, it sounds kind of like who cares about that? But that's really important when you have sickle cell disease, is taking care of yourself, with a good diet and lots of hydration and stuff like that. And then on top of that, some kind of medication. But if your life is in the hospital, then you have to, go one step further than that, than hydroxyurea, and then expect to whatever the big intervention is to end up just taking hydroxyurea. Getting blood transfusions has a lot of complications to it. It's not a nothing thing. It's not like getting an IV. It can if it is be an issue. And if you're getting, like I said earlier, if you're getting blood transfusion, make sure you get phenotypically matched blood. And the person who's giving you a transfusion kind of looks at you like, what are you talking about? Then you need to find someone who knows of how to transfuse people with sickle cell.
And that kind of just goes into the next question that I saw come through, is how to stop frequent hospital visits. Hydroxyurea could be another way to do that as well. Um, Blood transfusions. my sister is on apheresis, and she does that, and it keeps her out of the hospital. Or it, I guess, reduces the amount of times that she's in the hospital. So, um, out of those two options, I just feel like those are the two main options are hydroxyurea and blood transfusions. Is there anything else? And then of course, like lifestyle, right? Eating healthy, getting in your exercise, and just like, just healthy living, mental health as well. Um, yeah, how else, what other ways can you think of to stop frequent hospital visits?
Well,
Indari, maybe?
yeah,
Indari?
Indari. I mean, with hydroxyurea, you can take other medications. Indari would be, if I had sickle cell disease, Indari is a hassle, sort of, because you got to take it twice a day. It's a powder. Da, 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 da. But it is one of the medications, or it's not even a medication, it's a amino acid that has been shown to decrease pain in people with sickle cell disease. And it's not a pill, it's a powder that you have to take twice a day. But if you take that with hydroxyurea, I would personally think that that would not be a bad thing to do. It's something you need to talk to your doctor about. If you're doing two different kinds of medications, you got to let him. The other thing is you have to let your doctor know everything you're taking. So there's a lot of herbal medicines, alternative stuff that you're taking that that you need to let your doctor know because there could be interactions between those and the medications that your uh, sickle cell doctor wants to give you. And on some medications, some herbal medicines and stuff require that you have testing to make sure you don't have problems with your liver or other things because your liver detoxifies everything that goes into your body. And there are some problems with um, that natural herbal medicines. Some of them you just have to be sure that the people you're getting that the where you're getting them, you're getting what you think you're getting, not something else, and it's not contaminated with something else.
So
But
yeah,
go ahead.
I just want to say it showed that, Indari, like, within their study, it showed that Indari, which is the L-glutamine powder, pharmaceutical grade. So if you see like L-glutamine at like a nutrition store, it's not quite the same thing because that's not pharmaceutical grade. And so and Endari is, or that L-glutamine Endari is pharmaceutical grade. But it did show that it reduced the amount of hospitalizations. And so I think those are the three options are Endari, like what Dr. Q said, that's an amino acid. It's naturally occurring within your body. So um, it's not really a pharmaceutical medication, I guess, or it's not really a medication, but it's found naturally within, it's an amino acid found naturally within your body. Two, blood transfusions, and three, hydroxyurea. I think those are the three options at this point to hopefully reduce the frequency of hospitalizations.
And you really need to talk to your sickle cell doctor to figure out
Yeah.
what is going to be the best thing for you. And there's fewer medicines than there used to be, but the medications and treatment that Cassandra just mentioned are what's available right now. There may be more in the future, like I said, but right now
Yeah.
those are the three things that we know works. And people with sickle cell disease are low in L-glutamine, and that's why the doctor, scientist person who's behind L-glutamine started in the 90s looking at, he discovered that people with sickle cell disease were low in L-glutamine, and from the 90s until it got um, approved in 2017 or something like that. He worked on it and did a lot of studies to show that it was effective in people with sickle cell disease. But it started out, he I can't remember how he did it, but he realized people with sickle cell disease were low in L-glutamine. And so he thought replacing that might be helpful. And it turns out it is.
I'm putting those therapies in the comment now. I just saw your comment to write those therapies, but it's Endari, which is essentially pharmaceutical grade L-glutamine. Autocorrect. It's hydroxyurea, and then it's blood transfusion or apheresis. Blood, which is a type of transfusion. Apheresis. Hope I spelled that right. Okay. So
So,
I just pinned that comment there.
so
Uh
if people don't know, there's simple blood transfusions where you just get an IV and they hang a unit of blood and they just give you, because you're anemic, usually, they can give you a couple of units or whatever to get your hemoglobin up to like 10 or something like that, 10 to 11. So that's one way to get blood. Blood contains iron because that's what helps carry the oxygen. And so when you get simple transfusions like that, you're getting a lot of extra iron. And eventually, after, I don't know, 10 plus transfusions, you start becoming iron overloaded. And then you have to take a medication to get rid of that iron. Apheresis or exchange transfusions means they're removing, when you come in and say your hemoglobin S is 40% or something like that. So they're removing the sickle cell blood and they're replacing it with donated blood. So end up with they usually increase your hemoglobin, but you end up getting um, you, essentially the same amount of blood that they take out, they put in. So you're getting less iron, or even in some instances, you're even losing some iron in that therapy. The difference is that it requires, in apheresis, you have to have a really good venous access because the IVs are running really fast. There's a lot of volume that needs to be taken out and put back in an hour and a half or a couple hours. So that requires some good venous access. The other thing when you're getting apheresis is you're exposed to more units of blood, whereas it may take 2 units just or three to get you to a hemoglobin of 10. When you're doing apheresis, you get 6 units because they're taking out 6 units of blood and putting in 6 units of blood to get your hemoglobin S way, way down, or even more. Usually not too much more than that, but your exposure to different um, donors is much higher when you're on apheresis. So then and anybody who does apheresis, they know what they're doing with blood. But you need to make sure that you're getting phenotypically matched blood if you're exposed to 3 or 4 times more blood than a straight transfusion. But you need to be phenotypically matched even for a straight transfusion. But any people who do apheresis, exchange transfusion, they know all that because they wouldn't be doing it if they didn't,
yeah. And
hopefully.
I see a couple comments here talking about iron overload. And yes, that's very, very true, which is why, you know, some people in the community, they take iron, right? And you don't necessarily, anemia, the anemia you're experiencing is not because of low iron always, right? It's sickle cell. Sickle cell is literally the cause of the anemia and not iron deficiency. So, if you are getting transfused and you're taking iron, you're adding that additional iron, which can cause iron overload and can shut down organs if you're not, keeping up with it, or if you're not taking, medicine to get rid of the iron in your body. So that's why I always say You may not always need to take iron or in your multivitamins. If you're getting transfused, you don't need that additional iron. And people seem to think that because they're anemic, it's because of iron and it's not because of sickle cell. So there's a whole bunch of different ways you can become anemic. And in our case, it's sickle cell. Now, can you have be anemic from sickle cell and be anemic from iron deficiency? Yes, but that's not always the case. And that was me at one point. But now I think I have higher iron levels because I've been getting transfused. And so once it reaches a certain level, I'm going to have to start taking um the iron chelation medication to get rid of the iron in my body. So hopefully that helps and makes sense. Somebody says I'm on a deferoxamine now, which is that iron chelation medication.
Yeah. And if you because because people with sickle cell disease are always anemic to some degree, if you are going to take iron or somebody's suggesting iron, you need to be tested to make sure you have iron deficiency. And that's the reason why your hemoglobin is lower. There's a lot of reasons besides iron that someone with sickle cell disease may have a dropping hemoglobin.
Yeah.
And that needs to be investigated. But for sure, there are people with sickle cell disease who have iron deficiency, and that's going to take your anemia and make it worse. But
Oh,
the problem with iron is your body doesn't have any way to get rid of it. That's why you have to take a medication. Normally, um, the iron that goes in stays there, and it's kind of like an evolutionary thing where you know iron you need iron to make blood, so your body never developed a way to get rid of it. So when you're getting transfusions, which is you weren't, that's not something that they were doing thousands of years ago. So
right.
that iron just stays there and it's very, very toxic. And there's no symptoms. You don't get any symptoms until you're in heart failure or liver failure, unless somebody needs to be monitoring you for iron overload if you're getting transfusions. It's really important. And you
Yeah,
need,
if you've had 10 transfusions, then you should probably ask your doctor,
yes.
what your
Yeah.
ferritin and get screening for iron.
Yeah.
10 is usually that number to keep in your head. If you've had at least 10 transfusions, make sure that you're not iron overloaded.
Yeah. So I think we can
Um,
do one more question because
I was gonna say, I know Dr. Q has to get going,
Dr. Q is a
so
grandpa and he has to go get his little granddaughter at daycare.
um, the you said one more question, Dr.
Yeah.
Q.
Well, yeah. I have to get in the car and go get her.
Here's one. What is the best pain medicine to have at home with you?
Well, the best pain medicine would be like some kind of pill, like whatever. Some kind of opioid pill. It doesn't really matter what it is because opioids are all about the same. You need to, again, work with your provider to make sure that whatever you're taking, he knows you're taking it, he's prescribing it, and that you're using it appropriately. It's really easy to get into trouble if you have a lot of opioids at home and you're taking them more than just taking a lot of them. So you need to monitor yourself and you need to have your physician part of the team that helps you with your pain. But the only thing you can really have at home is some kind of oral medication. Um, there's complications we could go into, but I have to go get my granddaughter. But there's a lot of complications to taking opioids, and you should only take them if you find you're taking them like every day for a while and your pain is not getting better or whatever, then the time to go see your doctor and find out what's going on. Why? Because there's things that can happen to you. Just because you have sickle cell disease doesn't mean you're immune to other problems. So if you're having
Yeah.
pain or some other kind of thing, don't just say, oh, it's got to be my sickle cell disease. It could be something else. And doctors make that
I
same error. Somebody comes in, oh, that must just be your sickle cell disease. We'll give you some opioids when really it's something else. So
You guys are making me blush in these comments. Thank you guys. It says I love you guys. I've sent so many hearts. Was that you sending the hearts? Thank you so much. I appreciate that.
thank
We have
you.
to be strong mentally also, and I've learned a lot, and I kind of feel relieved now. And thank you. Oh, I'm so happy. That
Thank
makes my
you.
heart sing. You guys just made my weekend. I appreciate you. Thank you guys so much for joining us. Enjoy the weekend. Dr. King, you want to wrap us up real quick? Real quick, real quick.
Yes. So this Sickle Cell 101 is all about education. Knowledge is power. So what we're trying to do is educate you about sickle cell disease and about your specific questions about sickle cell disease. But even though we talk about different kinds of therapies and stuff while we do this, we're not really advocating that you do anything. You should always talk to your personal care physician, your hematologist, your sickle cell doctor to have a plan for what is the best for you. And if you hear something on this program, then that's something maybe to talk to your doctor about and find out if it's okay for you. But we're not advocating that you take anything in particular. We're just here to give you information and not really even advice, just information. So thank you very much for tuning in today. We'll see you in
Yeah,
2 weeks, right? Or are
yes,
you
in
going to
two
be
weeks.
somewhere?
I'm gonna be here 2 weeks, I think.
Okay,
I'm pretty
great.
sure. Yes, thank you guys. If we didn't answer any of your questions, send them to
Yes, right.
ask@c101.org. Have a
Yeah,
wonderful weekend. Drink
yeah.
your water, rest, and have a little fun. Buy yourself a little something. You deserve it.
Yeah,
All right.
definitely.
Thank you
Bye-bye,
guys.
everybody.
Take care. Let me end. Bye,
Uh,
YouTube. Let's
that was
see.
fun.